So what I'd like to do over the next 30, 35 minutes or so is kind of review state of the art, if you will, where we are with imaging of the extracranial carotids. I'm not going to talk about the intracranial vessels because it's almost a sort of a separate discussion, but we're going to focus on extracranial. Quite frankly, we'll do a little bit more, I'll do a little bit more on the MRA than the CTA because we tend to do more of it at NYU. And one of the questions I always get asked is, which is the right test? And there is no answer to that question. It's whatever you feel more comfortable with, whatever your referring clinicians like, whatever fits into your workflow in terms of getting the patients through. They're both quite good. So that's not really the issue. The issue is maximizing the use of both. So of course we should take a step back, I think, and say, why are we doing this in the first place? It's just become such a common test that I think people sometimes don't focus on the underlying clinical issues. And I think understanding those clinical issues will also help you understand how we take advantage of the technology. So why do we study the carotid artery? I mean, it's pretty obvious. It's a significant cause of stroke. There's still a lot of debate in the literature as to what actually causes or is the significant cause of stroke. Is it purely an issue of stenosis and degree of stenosis, or is there something about the plaque itself that we can examine? Unfortunately, we tend to focus more on the former rather than the latter. I think the other important issue here is that there's two treatments available, or sort of two treatment arms available. One is the medical treatment arm with either anticoagulants or antiplatelet drugs, and the other is the surgical arm, which I should now really change that and say surgical/interventional, i.e. carotid stenting, as an alternative. And frankly, at this point, the decision about, we make the decision about which of those two arms of treatment the patient has. If the stenosis is at a certain level, the patient goes on to surgery or stenting. If not, they stay on medical therapy. So, just a quick review of how we got here in the first place from the clinical point of view. The NASET and the European Carotid Study Trial, or the ECST, basically showed the same results. And they're several years old now, but nonetheless, I think still important to review. They both showed that there was a benefit to carotid endarterectomy if the stenosis was greater than 70% and less than 99%. Now, I should point out that that's not been proven for stenting. There are some stenting trials. The biggest one is the CREST trial that's actually looking at that, but nobody has done it so far. As you know, the data was strong enough to halt the trial. It was a 20% risk reduction in the 5-year risk of stroke, which is a pretty significant risk reduction. There's not a heck of a lot of stuff we do that has that kind of effect. The interesting data is is in the second bullet down here, which is that there was also a benefit to endarterectomy if the stenosis was greater than 50% but less than 70%. And this is the part that's a little bit tricky because the risk reduction was only 5%, so that's not that great. And therefore, the mortality and morbidity associated with getting the patient through the preoperative workup and then the operation had to be less than 3%, otherwise the numbers fell apart. So this is where we kind of come in, because all of the NASET and ECST trials were done with conventional diagnostic angiography, as opposed to using MRA or CTA. So we can immediately basically take 1 percentage point off the morbidity and mortality numbers because we're not doing an invasive study. And that's where a lot of what we do becomes significant. Now, this is still sort of debatable. There are surgeons who operate between 50 and 70%, and there are some who don't, and likewise for stenting. But this is kind of where the focus is. There was no benefit if surgery was performed in studies in patients with greater than 30% but less than 50% stenosis, and as you can imagine, in normal patients, surgery was actually harmful. How was stenosis measured in all these cases? It was measured this way, which is the narrowest diameter over the normal distal vessel. It was not looking at the bulb itself. It was measured this way because it's the most reliable way and reproducible way to measure it. Obviously, the stenosis is actually even greater if you think that the normal carotid bulb is larger than the normal distal carotid. But given that as it is, that's how it goes. A lot of people ask me, do you measure every case? And the answer is no, we don't. We tend to bucket them, mild, moderate, severe, occluded, just because it's easier. And quite frankly, I don't think our surgeons, although they'd probably deny this publicly, want us to give them a measurement because if it was 68% versus 72%, that might change how they operate on the patient or don't operate on the patient. Near occlusion is an important issue because in near occlusion you get a very slow flow here that progresses distally. So therefore the distal vessel will not be of a normal caliber, and therefore you can't really use the stenosis measurement. Near occlusion is 98, 99, 99.5%, that kind of thing. One thing that's important to remember, though, is that there's no benefit to surgery in those patients anyway, so that's kind of a key issue. This I put in here because I think it maybe should change how we think about some of this, because there's been some recent work, and the references there at the bottom, trying to look at what are called the subgroup data, i.e. take the whole NASET and ECST patient population and subdivide them into different segments and see are there some groups that do better rather than others. And interestingly, there was a benefit to endarterectomy in older patients, kind of makes sense. In men more than women, I have no idea why that is. After a stroke rather than after a TIA, also sort of makes sense, suggests that maybe there's some more serious thing going on. And if you can demonstrate ulcerated plaques. This is probably the most interesting, which is that there was reduced benefit to intervention if it was a long time after the last ischemic event. So those are just issues to keep in mind as we work up these patients. One word on asymptomatic carotid stenosis. Asymptomatic means a patient who has no symptoms, but the doctor puts a stethoscope on the neck, and here's a carotid bruit. So these are not normal patients. They're just patients with no symptoms. And there was the ACAS trial that showed a small benefit to surgery if the stenosis was greater than 60%. But on the other hand, there's also a small underlying risk of stroke. So how many patients do you really have to do to make it worthwhile is the question. Yet the recent data suggests that 50% of all of these surgeries being done in the United States right now are being done on asymptomatic patients. What that says about our surgical colleagues, I will leave for you to imagine. Okay, now let's switch and talk about the imaging tests themselves. So first, we still do a certain amount of non-contrast MRA. We do a lot of contrast studies. Now most of our studies are contrast, but we still do the non-contrast. And I want to focus on that, not so much because it's historical, but because there are different effects that you see from different kinds of stenoses. So when you get a high-grade stenosis, you get a high-velocity shear. So here's a moderate to high-grade stenosis on angio. On the 2D study, you're seeing that there's sort of an overestimation of the stenosis because you're getting a shearing effect along the vessel wall, and that causes turbulence. That turbulence causes dephasing of the spins, and therefore you don't get signal back. On the 3D, that goes away because the echo times are much shorter, so therefore there's less chance for dephasing. Why is this important? It's important because you have to look at the different techniques and understand what you're doing. And one of the things that's different for those of us who trained in the conventional angio days is the following. In conventional angiography, we used to say, find the view with the greatest degree of stenosis, and if we took 2, 3, 4 views, whatever it was, find the view with the greatest degree of stenosis, and that's the one that you put in the report. So if the AP showed 50%, but the lateral showed 75%, you'd go with the 75%. That's different when you're comparing MRA techniques, 2D, 3D, contrast, etc. It's true in the sense of find the greatest view, which projection shows you the greatest degree of stenosis. But find the MRA technique that shows you the least degree of stenosis, and that's the one you put in the report, because that's the one that's going to be closest to what an angiogram would look like, because that's the one that has the least amount of phase effects and turbulence effects. So that's an important issue to keep in mind. The opposite is true with slow flow. So when you get to a high degree of stenosis, as you can see here on the 3D, you really can't see the vessel very well, but on the 2D you see it better. So again, in the previous case here, we would go with what the 3D showed. In this case here, we would go with what the 2D showed if we were doing both techniques. That's why, by the way, we still do multiple techniques, at least a non-contrast and a contrast, just so we have an option of looking at different techniques. The 2D versus 3D, the way the MIP works is it takes a whole chunk of data you got there, it throws out about 95% of it, it keeps a little bit of the data, the brightest pixel, and that's what goes into your MIP image. Well, if you happen to be throwing out the important data, if your machine happens to throw out the important data because it's not quite as bright, then you'll overcall the stenosis. And that's so that whenever we do this, and this is true for, again, for contrast, non-contrast, whatever, we always go back to the source images. I'll tell you that personally, I sometimes, if it's totally normal, if you look at the MRA and it's a completely normal study, I may just skip the source images on that point because then I'm not worried about throwing out data. But on the other hand, if there is anything abnormal, I go back to the source images, just, particularly on the PACS workstation, you just scroll through them and you get a quick sense of what's going on. And here's an example where you can actually see that small internal carotid that you might not have seen on the MIP. So how do we do contrast MRA, which is pretty much 90% of what we do now, along with other stuff, but most of our patients are getting contrast. It all relies on the fact that contrast is a short T1 in the blood, gives you very high contrast to noise ratio, but we're scanning very quickly because we don't want to get venous contamination. So what does that mean? That means that we end up having to sort of catch the arterial wave. The problem with that is that we sometimes sacrifice some resolution because of that. So it's a bit of a trade-off, contrast to noise versus resolution, but that's the only way to do this. And obviously, the newer the scanner, the more powerful the gradients, the faster you can scan and the easier it is to do this stuff. As I said, the timing of the scan becomes important. You want to time the scan so it matches the central K space, which is where the bulk of the contrast is, and I mean the image contrast, not the intravenous contrast. That's going to show you what's in the image, and therefore you want to acquire that during the arterial part of the injection rather than when things are in the venous enhancement phase. So there are two ways to do that. You can either just start scanning and then keep repeat scanning as you inject and acquire multiple data sets, as I'll show you in a second, or you can do a timing run. I think most people today do a timing run, but here's what happens. So this is the pre-contrast study. Don't see too much except for the fat. Sorry, first acquisition about 20 seconds, and you clearly see the vasculature. 40 seconds, by that point you're already getting venous contamination of the jugular. Can you read through this? Sure, particularly if you cut it and rotate the image, et cetera, but it's not so great. And finally, by the third acquisition, it gets really hard to read through because there's so much venous and soft tissue contamination of the contrast. So we do a timing run. This is basically how we do it. The idea is just to find the point in time when the contrast arrives at the carotid bifurcation in the neck, and then you do a short calculation here, 2 seconds times that image, and that tells you your delay time. I will tell you, if you want to cheat, in most patients the delay time is about 18 seconds. It takes about 18 seconds from the time you start injecting, and by the way, these are all with a power injector, to the time that the contrast is at the carotid artery. Between 16 and 20 seconds, in that range. The problem with cheating is that it doesn't always work. And who do we study in these patients? In this situation, we're not studying young, healthy people. We tend to be studying old people with multiple system disease. They have cardiac disease, they have other diseases, et cetera. And particularly if they have cardiac disease and their stroke volume is down, then you can start dragging this out to 24, 28 seconds, and that's the problem. So we tend to do the timing run just because it's faster and more it's not faster, it's just because it's more accurate in terms of getting the exact time. So this is sort of the state of the art, I would say, in how this works. You can get the entire arch and carotids all the way up to the intracranial bifurcation here in one shot. It's important to show all of this, as I'll show a little bit later too, but it's important to show the whole vascular tree because of the issue of tandem lesions. Certainly looking at lesions in the region of the aortic arch is very important. Why? Because they're fixable. And so if there's a high-grade stenosis at the carotid bifurcation, but there's also a high-grade stenosis at the common carotid origin, it doesn't do much good to fix the bifurcation unless they can address the problem at the carotid origin. So the surgeons or whoever's taking care of this patient want to be able to know the full range of stenosis, including theoretically the intracranial vessels as well. So what are the advantages of doing contrast? Just to remind you, so here was a non-contrast study, a high-grade stenosis, and a kind of some slow flow petering out after that. And you clearly see the region of stenosis on the contrast study. The other advantage I would tell you is that you're really also seeing the length of the stenosis, which is important. Not only do we tend to overestimate with the non-contrast study on the degree of stenosis, 70% versus 60%, because of the turbulence effects, we tend to believe that stenosis is longer than it actually is. And that can be important in surgical planning as well. So understanding that can be helpful to the clinical colleagues. Another example that kind of demonstrates the same thing, 2D time of flight over here. Notice that this seems like a very long stenosis with then some residual region of stenosis that's only moderate going distally. Here's the contrast study. It's actually a very tight, short region of stenosis with a post-stenotic dilatation. And it's that post-stenotic dilatation that's causing turbulence and retrograde flow that's causing you to lose some signal on the non-contrast study. So putting this together gives a much better view to the surgeon about what's going on here. The uncooperative patient, obviously, if you can get them to agree and consent to the contrast injection, then you're doing a 30-second or 40-second injection, a study following the injection, rather than doing a 10-minute or 8-minute time of flight examination. And so therefore, they're just more likely to tolerate the examination well. Ulcerated plaque is kind of an interesting question. Clearly, you can see what looks like an irregularity or an ulcerated plaque on the contrast study, much better than on the non-contrast study. It's an interesting question because it's really debatable as to whether this is true ulceration we're looking at or just irregularity along the wall that doesn't actually have platelet formation and platelet aggregates sitting in it. We can't really tell whether the intima is denuded. We're not looking at intima. We're just looking at the flow. And so therefore, it's a little bit of a challenge. But clearly, we get a very good view of the irregular wall vessel, and that's how we describe these primarily. One of the other major advantages to contrast is the ability to look at the vertebral arteries. As most of you know, vertebral stenosis either happens at the origin of the vertebral arteries or at the junction with the basilar, or obviously in the basilar itself. There's very little atherosclerotic disease, if any, that happens in the cervical portion of the vertebral artery, other than things like dissection, trauma, et cetera. But pure atherosclerosis is very unusual. So with the non-contrast study, we of course couldn't really examine that. Now with the contrast study, we can, and you can see here there's a tight stenosis at the origin of this right vertebral, and there's sort of a moderate stenosis, I can blow this up actually, at the origin of the left vertebral. So this is someone with bilateral vertebral stenosis. That's a bad thing. If you have only one that's kind of out, you can probably do okay, but to have bilateral stenosis is a problem. So this is really important, and I would encourage you, as you do these contrast studies, really spend the time, again, look at the source images if you need to, but find the vertebrals and document what's going on with them as well. Similarly, we should be looking at the origins, as I said, from the arch, but also, just anomalies that happen at the arch. Here's an aberrant right subclavian that actually comes off after the left subclavian, and the common carotid is coming off in a common trunk with the left common carotid. So just describing all of this anatomy becomes useful. In this case, I don't think it was clinically going to change what they did because there's a high-grade stenosis of the right internal up here. But on the other hand, it was important just to know for future reference. As I said, I think the key issue is to look for tandem lesions when you're looking at the contrast-enhanced study. So here you have an example of a severe stenosis in the internal carotid, just distal to the bifurcation, and there's sort of a moderate stenosis down below. And the combination of those findings is important, and it actually does change the surgical management of these patients. One of the things that you can see on the contrast-enhanced study that you actually really couldn't see very well on the non-contrast study is fibromuscular dysplasia, which, as you know, is sort of this abnormality of the media of the vessel where you get this beating of the vessel, as it's called, which you can actually see here. And because we're just filling out the vessel better with the contrast, seeing the margin of the wall better, of the lumen better with the contrast, we can actually detect this now. And so you have to be careful not to overcall it because there are all kinds of artifacts that can create a similar appearance. But when you see a long stretch, as you see here, that's a good 2/3 of the cervical carotid that has that kind of beaded or irregular appearance, then you should be thinking about fibromuscular dysplasia. This is usually not causing significant stenosis, but rather just this vascular irregularity, which actually can, in some cases, later produce other abnormalities. Dissection is hard on a contrast study. It's hard, actually, in general, if you don't look at conventional T1 weighted images, because the hematoma may not be particularly visualized, and that's the best way you're going to tell the dissection. So if I looked at this image here, quite frankly, I would have just called this a region of stenosis, and it was the clinical history that made us think, well, is there something else going on here? This is a patient who presented with acute neck pain and some intracranial symptoms. So we were thinking dissection, and that's why we kind of thought about it. And here is here's the hemorrhage in the lumen of the wall of the vessel, rather, the thrombosis that's happened following the dissection. Now, quite frankly, would I have picked that up on the contrast study alone? No, I probably wouldn't have. But the clinical story kind of swayed us in the right direction here. The other thing I want to just draw your attention to, although it's not related to dissection in this case, is this sort of loop-de-loop or kink in the vessel. This is also one of these sort of controversial areas. There are surgeons who believe that these can actually be flow restricting. There's not a lot of data, by the way, that supports that, but there are surgeons who believe that. And so what they'll do is, if they're going to operate on this patient, which in this case they wouldn't, but if they were going to operate, they would try to open up or fix that kink, meaning by pulling the vessel down or at least repositioning the vessel in some way. I'm not aware of people who will actually operate to fix the kink alone, but if they're going to be there anyway, they're going to do that. So it's one of those things that I always put in the report just to alert them that this situation exists. Sometimes, if you look at the way the vessel is kinked, you really could believe that it's a flow-restricting lesion. It almost looks like a garden hose that's been folded back so tightly on itself that you wonder how blood is flowing through. And that actually might be, in the future, a use of looking at flow quantification, which we can do in MR, obviously, as well, to sort of see if there's a flow-restricting lesion there. One of the things I just comment on also is, and this patient has all kinds of stuff going on here. There's an AVM in the neck, but there's marked irregularity to the aortic lumen. And so this is a patient, obviously, with atherosclerosis. There's marked diffuse atherosclerosis of the lumen. Again, it's just one of those things that you ought to put in the report, if nothing else, because this patient could be having renal insufficiency, all kinds of other problems related to the more generalized atherosclerosis. So we would include that sort of as part of the dictation. Now, one of the nice things, actually, about moving to 3T is the quality of the MRAs. And because the T1 contrast is inherently better at 3T, you get this really bright and good quality image. And actually, you can see here that you can actually see distal vessels much better than we can at 1.5. I'm not saying that this is the only reason to do things on a 3 Tesla, but it does certainly have the advantage. The other comment I'd make is that we still do our MRAs at 1.5, and they're fine. But it's just one of the things that's out there that I think, as people are looking for reasons to buy 3T, this is certainly one of the ones that people are looking at. This is, again, a 20-second image with a pretty high resolution matrix, which is the other thing here. So this is actually higher resolution than our standard 1.5, which is running below 512 on the matrix side. Now this is sort of, let's see if I can get the thing going. Here we go. The next idea in MRA, which is to look at sort of time-resolved studies, or a 4D, if you will, MRA. And one can view it sort of as each image, or you can just watch the time course of the vessels. The role here, I think, is going to be for not so much for looking at degree of stenosis, but for looking at other lesions, again, like AVMs or areas of questionable flow, fistulas, et cetera. And I think there'll be some role for that in certain select patients. The advantage, again, is that if we can increase the temporal resolution, we can start to look at how the arterial and venous phase work together. And this is a lot easier to do at 3T because you have the signal back to do that, and therefore you can sacrifice a little bit on imaging time so you can acquire more quickly, and thereby, but you still have enough signal, so thereby you still get a good quality image. And along those lines, the whole concept of sort of whole body imaging, which didn't get great favor in the CT world, but in the MR world with some of the systems, and this is sort of a mock-up from a Siemens TIM system or Avanto system, with all of these coil elements, allows you to look at multiple body parts at in one quick setting. So what you can do, you can get sort of the muscle man here image, which honestly, I don't know how valuable that is, but I think there's going to be some interesting question, and we're actually doing some research in the whole concept of MRA screening. And you can do basically, head-to-toe imaging in a few minutes. The idea being that if a patient has a high-grade stenosis of one significant vessel, like you see here with the carotid on the right, it's also likely that they have other vessels that are abnormal as well, and in this case, the renal. So the question is, do we limit our evaluation to just the area of interest, i.e. the carotid arteries, or do we do sort of a whole body study and then segment out parts of it to try to give a more complete picture? One of the arguments would be is that as the therapy moves more and more towards an interventional-based therapy, that is stenting, angioplasty and stenting, should the therapy include multiple areas of therapy, not just the one that takes the patient to the doctor in the first place? So let's, for the last 10 minutes or so, let's switch to looking at CTA. And there really are two large applications for CTA. This one, the trauma one, obviously is not an application that MRA plays a big role in because we tend to have CT scanners more easily available, but atherosclerosis is basically the same. Here's our sort of CTA carotid protocol, pretty standard, and this is done either on a 16 or a 64 slice scanner. It's basically pretty similar. Part of the whole issue in CTA is how do you reformat these images. Obviously, you can do a MIP, which is the easiest thing to do. It's a little bit more difficult intracranially because of the bone, but in the neck it works out pretty well. You can also do volume rendering, as you see here. Part of the issue rather is how do you keep the vessel but get rid of the bone. One way to do that is with sort of a subtraction technique using this non-contrast, low MAS data set just to give you the bone and then subtract the two images out. The more interesting way might be, and this is early to tell, using dual energy. So Siemens just announced, and they have some pictures out front, a scanner with two heads or two tubes and two detectors. And in theory, what you could do with that is run 2 kVs through it and thereby getting images that are different between the bone and the vessels and do an automatic subtraction in real time without having to actually remap the images to one another. And that would be very cool if that happens. It's a little bit early to tell, but that's kind of where some of this is heading. Obviously, the same issues about atherosclerosis apply to, CTA. In terms of looking at the vessel, looking at the source images, et cetera, et cetera. And again, on a PACS workstation, these become really pretty easy to do because you can sit there and NPR them to your heart's content and make sure that you're really getting an accurate view of the vessel. One of the things you can do with CTA, which is a little bit different, is you can sort of start to look at the constituency of the plaque. Obviously, most people are aware, and I'll show you in a second, of calcified plaque, and there certainly is a lot of calcium in some of these plaques. But sometimes you get these sort of fatty deposits, as you can see here, and so that can be an important thing to mention as well. It may change whether the plaque is stable or unstable, and there's a lot of research that needs to go into evaluating whether or not different plaque constituencies have a different outcome long-term, or is it, again, just a question of degree of stenosis? My own feeling is that it's going to be a combination of both. Obviously, if you have severe stenosis, that's one thing, but those patients who go on to stroke who have a moderate stenosis probably have something in the plaque that predisposes them to have further problem. And here's the conventional angio on that patient. And again, you can, with the software now, the sort of modern software, you can get rid of some of the calcium, which is an advantage. It doesn't totally get rid of it. You get these little sort of balloon artifacts. It's easier for me to see it on the screen here than up there, but it's on the CD anyway. And this is useful because it gives you a better sense of what's going on with the vessel itself. Sometimes the calcium can actually obscure your view of the vessel. If you're seeing a MIP and the calcium is obscuring your view of the vessel, again, you can either play with these kinds of techniques. The simplest thing to do is just go back to the source image. The data is there. You can see the calcium. You can see the contrast next to it. You can window and level it to your heart's content and make the differentiation. Here's another example where it really does kind of obscure what's going on at the image, at the bifurcation. High-grade stenosis, two different views. With CT, you get this sort of marked areas of plaque evaluation, which you can see better. But again, you want to comment on it. How much of it's calcified, how much of it's not, long segment of stenosis versus short, et cetera, et cetera. Again, you can look for ulceration using CTA. This is kind of a nice example of what really looks like a true ulcer, even a little like a flap there. But even beyond that, look at all the irregularity in the proximal vessel before you get to the large area of ulceration. It's that irregularity that's just as important as the ulcer itself, because there may be small areas of intima that have been denuded in those areas that are sites for platelet aggregation. Carotid stenosis, again, look at the source images. Here's the MIP. Here's the source image. You actually see the vessel walls a little thickened here. Here's the plaque with some fatty components in it. It just confirms what you're looking at. Occlusion, basically the same as MRA. You want to look for distal flow if you can find it. In this case, you really can't. You kind of question whether something's going on here, but it's hard to tell. Some issues in terms of carotid CTA, particularly in looking at the atherosclerotic patient. This is a little bit old now, but the ideas are the same. The axial source image data, as we talked about, the volume reconstructions, or SSDs, surface shaded display reconstructions, may actually underestimate stenosis. It's the opposite of the MIP. So the problem with all these different techniques is you can have slightly different effects on the data. So therefore, you may not see mild stenosis quite as well. Does that matter? I'm not sure. It's a good question. The bigger issue is converting a severe stenosis into a moderate stenosis. And then you have these issues as well. One of the easy artifacts to pick up is just a misregistration artifact from swallowing, because you get this line that goes straight across the whole image data set, because that's where the patient moved or swallowed. With the faster scanners and this they get faster and faster, this becomes less of an issue. A couple of words now on trauma. Basically, at least at our institution and Bellevue, which is a huge trauma center that we cover, CTA has basically replaced conventional angiography for penetrating neck trauma. And this is after some particularly good studies that were done and published in Radiology several years ago. The idea being that you can do a quick CTA and as part of the trauma workup in general, because a lot of these patients are getting now total body CTs for their trauma workup, or at least looking at the affected areas, and you can do the CTA, answer the clinical questions about whether there's a pseudoaneurysm or a true leak, and dispense with doing an angiogram. So for hemodynamically stable patients, we have pretty much completely replaced conventional angiography at night, which makes our fellows as well as our attendings quite happy. So you can also see dissections, as you can see here, which is obviously related to trauma. Obviously, in the middle of the night, we don't do these pretty views. We do a quick MIP, or maybe even just look at the source images and try to work it up. But for a presentation like this, you spend another 5 minutes and make it look good. So just to summarize, MRA versus CTA, your call. Whichever, as you can see from the images, they both work well. They both demonstrate what you need to show. But it's whatever easier and more convenient for your patients. Obviously, there's a radiation effect as well. Secondly, I say 3D image processing, but I would just sort of say image processing in general. Be careful when you process images, because you're doing stuff to the data, and whatever you do, you can change the outcome of what you're looking at based on the image processing. It's nobody's fault. It's just how the system works, and you just have to be careful about it and use and have available the source images. And remember, on the CTA side particularly, it's not only atherosclerosis that we're looking for, but trauma and other diseases as well.
Does it make a difference about the field of view with CTA is much smaller than MRA? Isn't that a big advantage for CTA, higher spatial resolution?
Why don't you come up here, Andy?
You sound like a partisan. Yes, the resolution is better on CTA. There's no question. Does that matter? I can't say that we've seen it matters clinically. In theory, you would think that it would, but I can't tell you that we've seen clinical examples that show that.
Anyone else? Yes.
Did I understand you to say that early on that in these very tight stenosis, knowing yes or no if it's open or closed is no surgical, that you don't do surgery on those?
The question was, in the very tight, quote, near occlusion, I think that's what you're referring to, stenosis, does that change the surgical outcome? The answer is, when I was trained, it did. It means they went right from the angio suite to the operating room, and that's kind of how we thought about it. The problem is that the data says that it doesn't. The data says that those patients shouldn't get surgery. So,
is that because they have balanced circulation already?
Yeah, that's the presumption. And if they close, it won't make a difference. I guess the answer is, what do your surgeons do and what do they want? I mean, you know, that's our job really, is to provide them the information they want. But I was quite surprised when I read some of those articles, and it suggested that there's absolutely no benefit in the 99% stenosis to endarterectomy.
Yes.
Could you comment on the difference between MRA and CTA in terms of assessing for dissection? Because on MRA, I feel very comfortable using the axial source images and looking for the bright T1 signal, looking for mural thrombus. On CTA, of course, you're looking for, I mean, on the reformatted images, you can see the vessel, the contour of the vessel quite well. But in terms of looking for intramural thrombus, do you feel that one's more advantageous than the other?
What do you think?
In terms of CTA, in terms of dissection on CTA versus MRA?
Quite frankly, I don't know that I have enough experience, you know, both ways, where we compare one to the other, let me say it that way, to tell. And by the way, Dr. Pramanik is still here, so you can ask him questions also. But I'm getting a little tired of this. But my sense is that we're going to do increasingly more CTA just because it's more available. But I don't know the answer to your question. I don't know whether anybody else does.
I tend to look more at irregularity of the lumen in the right clinical setting on CTA. You're right, you're not going to see the mural thrombus, which MR is going to be much more beneficial for. But typically in a young patient with the right setting of the history, when you reformat your images, you can see this dramatic narrowing, and those findings are suspicious for a dissection, and occasionally you may see a flap, but more than less likely.
The images were very nice, particularly of the arch and the origins of the cervical vessels. I can't say that the ones that I work with are quite as, you know, as good. What strategies have you employed at improving the visualization in this area? These are also decidedly better than those that were seen 6 years ago and 4 years ago.
I'm sorry, you're talking about CT or MR or both?
Particularly MRA with contrast.
I think the difference for us, and yeah, so let me just say, this is all based on the Siemens imaging, the Siemens systems, using the TIM, which is their multi-channel coil system. My own view is it's the coils. Is that what's changed in MR, at least for us with the Siemens equipment that we have, and each vendor is somewhat different, but what's changed in the last 2 or 3 years has been this ability to do these multi-channel coils, which really rapidly increases your signal to noise in a relatively shorter time frame, because you can get better data. And that's part of the reason, by the way, that the stuff off the 3T even looks better. So I think that's the issue. I mean, you'd have to look at exactly what the parameters were, et cetera, but I think that the coils are where the next trend in MR is going to be. I mean, if you think about the late 90s were sort of the era of the gradients, and everybody was saying, oh, my gradient's bigger than yours, kind of thing. And now I think you're seeing a bigger shift towards improving RF and coil design as where things are going.
Yes.
You showed a patient with a dissection in the neck and then a loopy distal cervical internal carotid artery. And what were you postulating about the mechanism? You said you were
Okay,
using...
so I wasn't postulating anything about the mechanism of either the dissection or the loopy vessel, the kinked sort of looped vessel. What I was trying to do was just use that image to show you the dissection, which was there, but it's sort of a completely separate issue to talk about this controversial area of whether that means something to have a looped or kinked vessel. And as I said, some surgeons believe that it does mean something and it is significant, it should be treated, and some think it's completely bogus. Those two are not connected in any way, except that by convenience they show up on the same slide. I hope I wasn't misleading on that, I'm sorry.
No, I think that's what you said. Our experience is that, how old was that patient, do you know?
I don't remember, sorry.
That in the younger patients who dissect in their 30s and 40s, it's a common association. And if you look on the other side, you'll frequently see the loop without the dissection. So my impression, just anecdotally, is that the loop precedes the dissection and there's something wrong with the intima generally.
I think that's a fascinating theory, and I'd love to help you write the paper.